Good afternoon, everyone. My name's Kathy Harley. I'm the CEO of Nurses Specialized in Wound Ostomy Continence Canada, and I would like to welcome you to our continuing education webinar, which is the Future of Nursing and Wound Care, Integrating Technology for Improved Wound Care Delivery. So today you will be hearing about the value that technology can bring in breaking down geographical barriers within your province and supporting more equitable healthcare. And our presenters, we have three presenters who I'll introduce in just a moment, but they're going to be talking about the latest technology in remote wound care and how this as a tool can help support nursing practice. They will touch on effective strategies for using technology to enhance wound care. You'll learn some more skills around using technology in wound care. And then they'll talk a bit about some case studies and bring their own lived experience in using new technology forward. So it's going to be a really interesting session. This session is being done in partnership with TeleView, and I would like to thank Ryan Delarami and Brad Boosie for their support in bringing this education to you today. And now I would like the opportunity to introduce our three speakers. The speakers will be presenting one after the other, and I would encourage you to put your questions in the Q&A box, which is at the bottom of your screen. So if you put them in there, we will do a facilitated question and answer at the end of the session. So the first presenter will be Allison Luther. She is an occupational therapist and has a master's of clinical science in wound healing and is the manager of the regional wound care program for St. Joseph's Healthcare Group in Thunder Bay, Ontario. Her role largely includes equity and access to evidence-informed wound care, which leveraging virtual technology plays a huge role. Allison is currently the implementation lead for the lower limb preservation program in Northwestern Ontario, in which TeleView has been deployed across 9 sites to improve wound healing outcomes in Northern Ontario. So welcome to Allison. Our second presenter is Prachi Sharma, who is a versatile professional currently leveraging her skills as change management lead at St. Joseph's Care Group in Thunder Bay, Ontario, to drive organizational transformation and effectiveness. And she's leading the training and onboarding of the program across the 9 sites. And then our third presenter will be Judy Vondrasek, who is a certified nurse specialized in wound ostomy and continence. She is an advanced practice clinician in St. Joseph's Care Group in Thunder Bay, Ontario. She's been a nurse for over 20 years in various positions, but now she is in a very busy wound ostomy and continence clinic serving Northwestern Ontario. And she does practice both in person and through telemedicine appointments. And so now I would like to turn things over to Allison Luther, and please feel free to put your comments or questions into the Q&A box. So Allison.
Thank you for that great introduction. So I had a little intro that I'm not going to say now because you've done a great job of introducing my team. So as mentioned, I'm Allison Luther. I manage the regional wound care program for St. Joseph's Care Group. I want to thank TeleView today for sponsoring this session, as well as the Nurse Specialized in Wound Ostomy and Continence Canada for allowing us to present. So our land acknowledgement, we wish to acknowledge this sacred land on which many sites operate here in Thunder Bay. This land is the territory of the Anishinaabe Nation. It is also the place of the signing of the Robinson Superior Treaty of 1850 territory and the people of Fort William First Nation as signatories. So our learning objectives today, we're going to do an overview of the Health Innovation Technology Grant, which led to our initial pilot with TeleView Technology, as well as the Regional Wound Care Program. We're going to describe the technology used in remote care, illustrate integration of technology to coach wound care specific skills. We will do a case presentation and success and challenges. So the Regional Wound Care Program serves as a program lead, St. Joseph's Care Group serves as a program lead to promote integrated delivery of evidence-informed skin and wound care. The main goal is to build capacity as well as equity and access to everybody across Northwestern Ontario. We operate a centralized intake for wound care where we have 8 clinicians specialized in wound care who service an area roughly the size of France and a population of approximately 250,000 people. We have a lot of wounds here in the north. Here in Northern Ontario, we have double the provincial average of non traumatic lower limb amputations. We're actually the worst in the province. I'm led to believe we also may be globally significant in our amputation rates. Indigenous communities in Northwestern Ontario have 7 times the provincial average of non traumatic lower limb amputations, and 85% of these amputations are preventable. We are one of 12 demonstration programs for lower limb preservation, and we are in the process of incorporating this innovative technology into the lower limb preservation program due to the success of the Teleview pilot project that we ran from December 2022 to March 2023. So our problem statement: advanced wound care skills is a very scarce resource if you haven't picked up on that in Northwestern Ontario. We have a really significant rate of amputation. So how do we provide equitable access to service regardless of community or setting? How do we reduce travel burden and life disruption? How do we increase confidence of frontline clinicians who may not have a specialty in wound care? How do we provide immediate access to support, close more wounds, and ideally prevent limb loss? So this is our Teleview pilot project. So in the fall of 2022, we applied to Ontario Health for a health innovation grant sponsored by Boehringer Ingelheim, and we were selected as one of 4 sites in Ontario for this grant. So we were really privileged to be honored with this grant. It was a really great opportunity. The intention was to bridge the gap between equity and access to wound care, including peer mentoring, wound consultation, and care closer to home. And I can tell you that as the lead for lower limb preservation, every time I go to a community, I'm frequently told people do not want to leave their community for wound care services. So I really think this speaks to that. Our program was guided by the quadruple aim for healthcare, which was to reduce travel for advanced and specialized care, not reduce, but build provider capacity, confidence, and skills in wound care in Northwestern Ontario, with an emphasis on best practice, reduce ER visits because people really shouldn't have to go to ER for wound care, but it does happen a lot, as well as reduce hospitalization length of stay, improve timeliness to access of care, as well as client outcomes. Oh my gosh, I'm having a day, guys. I'm so sorry. Um, we also wanted to reduce the burden of scheduling because with some existing telemedicine practices, it actually leads to delays in care. I think that for me, when I set up an OTN, sometimes it can take up to 30 minutes. So this really expedited that. Okay, so our pilot logistics. So we offered 2 workflows. We had an on demand, so call us up when you need us on the fly. And we also had scheduled visits. This was a small pilot that ran roughly 4 months, but had a positive impact for wound care outcomes, as well as client and clinician satisfaction, which we'll explain in subsequent slides. Judy will share her experience through the case presentations. She was the first advanced practice clinician to ever use this type of technology for wound care. So I'm really privileged to be able to have Judy with us today, as well Prachi Sharma, our change management lead. She's responsible for the rollout for lower limb preservation, and she's been instrumental in helping keep this dream alive, we'll say. The logos listed here are the sites where we piloted this technology. The organizations listed are diverse. Some fly to remote communities, others service drive-in communities, and the remaining sites can be anywhere from a 2 to 6 hour drive from Thunder Bay. Now I'm going to hand it over to Prachi to describe describe the technology in further detail. Thank you.
Thank you so much, Alison. Can you say if you can hear me okay? Awesome. So before we talk about the new technology that we ended up leveraging as part of the pilot program and ultimately in lower limb preservation, let's briefly chat about the status quo. We originally had access to your traditional telemedicine camera and handheld camera. The location of the wall-mounted camera is sometimes not ideal when you're looking at the wound, which are on different location of a body part. And sometimes you definitely have to use a handheld camera while you're trying to show the wound to the expert on the other side, which means that most of the time you will require two clinicians to do that procedure. One needs to stay sterile and provide wound care to the client, while the other clinician need to actually hold the camera or help guide that. You can use these equipments, of course, to capture static images, which may, sometimes focus. If you actually look at the images which you take from these cameras, sometimes they can vary, like sometimes the color, sometimes the calibration, the proximity, all that technical stuff varies from who has taken the picture, what was the lighting of the room, how much the bandwidth was there. And let's not forget what Alison just mentioned, the administrative burden of booking an OTN call could be sometimes very cumbersome for some of our clerical staff. So moving along, we let's talk about what is TeleView. Why did we decide to go with that? So TeleView is a technology which allows a patient-facing clinician to connect with an expert user. While the technology itself is multifaceted, has multiple different solutions that I'm pretty sure if you actually do some research, you'll be very happy to know about. For our pilot program, we just focused on remote view and glass view. What that means is that TeleView has created an innovative technology, which is called TeleView, the software itself, where a patient-facing clinician can initiate a call using smart glasses and connect them to remote expert clinicians, such as an NSWOCC yourself. And it is like having an over-the-shoulder guidance in the room for the patient-facing clinician. In simple words, think about like if you do not know any procedure, how to do this, if you need that guidance, you need to build that confidence. This is like pulling an expert in the room, showing them the wound in the real time, and asking them, how can I provide better care? Moving along, let's look at some hardware. Alison, can we go? Thank you. Moving along, if we talk about it, there are two main components of this particular technology. I would like everyone to please focus on this image where we have two elements. One is glasses, the other one is dashboard. The glasses could be mounted on any frame, which in theory you can just wear just like how you would wear your normal glasses, or you can just mount them on a band, which allows a little bit more movement, as I've been told by the clinicians. Now, if you actually focus, there's that mini screen in there, which can actually show you what the expert is trying to tell you while you are actually in the call. So when you're providing the care and the expert is telling you, can you measure this wound from left to right or from this point to that point, they can annotate and you will be able to see that within that little mini screen and provide that care in the real time. Moving along, that dashboard user expertise is for somebody who is an expert, which means that any advanced practice clinician. Now let's going back to the example for the pilot program. An NSWOCC herself can look at it while logging in from her dashboard. I would just like to remind this thing that in this case for the pilot program, our advanced practice clinician was an NSWOCC. Actually, that is a picture of Judy on the right-hand side. For logging in, all she needs is access to internet and a computer. That's all. And for the patient-facing clinician, on the left-hand side, you can see that the patient-facing clinician is wearing the glasses and is providing care in the real life. Now the expert user can see whatever she's doing in the real time and can provide guidance. There are some features which we'll talk further about as we move forward, but I would like to highlight at this point that one of the main feature that we really like is that the glasses could be controlled by voice completely if you want. So that means that once you enter the call, if you've started the call already, you do not need to touch the glasses, touch the wound, and touch the glasses again, because that will not mean that the care is not being provided in the sterile environment. So moving along and talking about some useful features, let's talk about the first one, pause, zoom, light, mute. These are, I would like to highlight again, these are some of the features which could be controlled by the expert user, like an NSWOCC herself, while being logged into the dashboard. What that means is if the patient-facing clinician is moving too much, is not focusing, they can actually pause them in the real time. They can actually zoom it for them. Virtually, the patient-facing clinician is just a camera. It's just the other day, somebody said it's like a moving avatar in a video game. They are controlling that for you, and please, and they're controlling that for you while the expert is guiding them what to do. So think about it. Somebody sitting somewhere else can control the system. They can do multiple things like mute. And what that means is while you're wearing those glasses, this also has a camera attached to it. It has a mic attached to it. So you're actually listening to it. You do not need extra headphones. You do not need anything else. Going back to the screen annotation example again, so the advanced practice clinician, such an NSWOC in that condition, was able, in that example, was able to actually annotate on the screen and show like, oh, if you can just, measure it from left to right and front to center, we should be able to have a better look at the wound. Um, Another feature that I absolutely love is screen sharing, where the advanced practice clinician can share the screen and show that, oh, in this call, we were able to do these particular thing, all practices followed by Wound Care Canada, and following all the best practices, we were able to provide these care. Different other things could be done by sharing the screen, such as how to do a co-band dressing or how to do a particular dressing that the expert clinician has made it for themselves, and then they can share it with them instead of saying, oh, let me send you the file later on. And if you're on the call, you're able to see that in that little screen. Different other functions I would talk about, which have been told to me are very useful, are chat functions. Briefly saying that, the name of the medicine or name of something which you wanted with the spelling. Chat functions very useful, because again, in that little screen, if you're wearing the glasses, you should be able to read whatever the expert has said. It can toggle between different views. You can see your own view, you can see what the glasses are seeing. All of that is like, think of it more like high level Zoom call, but with more features, and you're able to control more if you are the expert user. You can add 3 different calls, 4-way calls, like you can monitor 2 glasses in the same time if you may. You can add 2 different expert users while there's only 1 glass on the other side. So that means that we can have all the expertise provided in the same call without scheduling again if it is on demand. Um, and then, of course, we can reconnect whenever there's a poor connection. So going back to the status quo example into this, I would say the resolution of the image is very high when we talk about wherever the resolution matter. Teleview's resolution is very good, like as compared to like traditional telemedicine. It's very clear. It's not that reliant on bandwidth as much as the telemedicine is, because it's just how it is built in the backend, and I can talk more about it, but I'm sure you're not interested to know the technical aspect of that part. Patient-facing clinician is hands-free, as we said, since it could be controlled by the voice, it could be controlled by the remote expert clinicians. So that just allows them to provide the sterile procedures without changing the gloves, without having to touch their glasses, touch their face, which we don't want. And we just need one patient-facing clinician because they are wearing glasses, and we don't need 2 to handle the camera. Now, with that being said, let's move to what we did with Teleview implementation in lower limb preservation. So we identified 9 different sites. We opened up the expression of interest. We got a lot of interest. With the funding, we were able to support 9 different, we were able to procure 9 different glasses for 9 different sites. And we have 4 dashboard sites where 4 different advanced practice clinicians, in fact, not 4, there are only dashboard sites which are 4, but there are more users actually on the dashboard sites. And then they are able to provide that support to all the glasses in the region. And with that being said, since the success of the Teleview pilot was so good, we decided to go ahead with it. We still have to onboard 1 more glasses at this time of the day today. But yeah, this is where we are with the Teleview implementation in Northwestern Ontario. Now we're going to hand it over to Judy for the fun part of the presentation, the case presentations. Over to you, Judy. Thank you.
Judy, are you having technical issues?
Allison, would you like me to go get Judy from that room if you want to talk about something else meanwhile?
You know
I
what?
can.
I'll if you can locate Judy and I'll just try to present on her cases, I can keep the presentation moving.
Awesome.
Okay, so that's fine. So maybe if you want to jump out and try to locate Judy. Yeah, thank you. Hi, everybody. I'm going to fill in. Okay, so because this is the best part of the presentation. Now, Judy had a note in her slide saying just to warn people, because if you're eating and you may not like the photos of wounds, there are going to be some pictures of wounds, but I think if there's wound care clinicians in the room, you can handle it. So I'll just give that as a precursor. Okay, so some of our successes. We have a heel wound here on the far left, and this client had not been referred to vascular. And then Judy was able to escalate this referral to vascular because she noticed, and she noticed that there was a really significant vascular concern. The clinician on the other end was not aware. And so just because, we're trying to provide provider confidence and build capacity in the Northwest. And so we were able to escalate this referral to vascular, and the client underwent a limb-saving procedure, which we were really, really grateful for. And the photo where you can see the toe wound, it's almost closed there on the far right, lower right corner. This is one of our favorite stories. I see Judy has joined us, so I'm going to let her take over. Judy, if you're ready, are you back and ready to go?
Yeah, can you guys hear me okay?
Yes, we can. Go for it.
Okay. Sorry, I'm going slightly mobile here. Okay. So these are, I'm just going to use my phone. Thanks, Prachi. So these photos was managed by general surgery in one of the remote areas. And of course, one thing that hadn't happened with this client is he hadn't actually been referred to vascular. So that was one of the recommendations we made in real time. And then for this client, he was found to actually have an occlusion, I believe it was of the SFA. And so he went on to receive that limb and also probably life-saving surgery. And that was what was going to heal that wound. This client in particular actually had attended our TeleVue visit with probably, I can't recall how many wounds, but at least 9. One of the other ones was what you see on your screen there. It's a scalp eschar that's present. That had kind of been overlooked. It was from a fall that he had likely due to some of that neuropathy. And so they had just been doing some dry dressings and trying to treat it that way. But we know the location of that wound. There's not a lot of fat there. And if I'm seeing eschar, it's probably down to the level of the bone. And having been open that long, I wondered if he might not have an osteomyelitis developing. And so we had actually asked the surgeon to look at that as well. And in fact, he did have osteomyelitis. So he underwent all kinds of care with vascular and for these other wounds. So that was sort of that coaching interaction that demonstrates what we're able to accomplish with TeleVue. One of the other stories we have on the right, you can see the, that's a lower leg. And we can see, sorry, can you guys still hear me? Okay, that's a lower leg, and we can see that there was a dressing on there. They had actually, every time they changed it, it was pulling off some skin. And this client had a Zimmer splint actually while she was in hospital that was also sort of slipping around. So again, that coaching piece to look at what's happening, what's the cause of some of these wounds, and some clinical direction with that was provided. So they involved their OT or PT just to get that splint resized, refitted, and adjusted correctly. And then we added the non-adherent contact layer to sort of stop the pulling of that skin, and that closed very quickly. On the bottom right, there's a picture of a foot there, and on it's her left second toe. This is a lady that was admitted in a long-term care setting in one of our agencies. She had had this wound present for 6 months, and they had access to very advanced wound care products, but perhaps weren't using them as well as they could have been. A lot of frequent changes, a very absorbent product for a not highly exudative wound. So we made some minor treatment recommendations, and within 11 days, that wound in particular closed. And so the lady was quite happy with that, as was the site. So a win for all of us when it comes to that for aims of healthcare. And really the stuff that we look at with these interactions, we're able to zoom in and see, we've got nice clear photos. These are all made possible by TeleVue. Let's take a look at another example. On the next slide here, this is a client that this really illustrates the synchronous care planning piece. So when you're in a call, being able to say, hey, you know, the nurse on the site is like, what am I going to put on this? And then being able to formulate that plan while you're with her and get a good assessment, him or her. So in this particular instance, this client had come from our regional center in Thunder Bay and back to her community hospital. And while she was there, the orders, I guess, that came from the physician didn't include things that they had on their formulary. And the nurse was really at a loss. And I know I'm guilty of this, and maybe some of you as well also do this, but we tend to make our recommendations based on brand names and maybe not by their generic or even categories. So that's really important in helping convey what it is we're trying to do. So together, we actually went and looked in their supply room while the clinician had the glasses on to go and see, okay, what else can we use? One of the other things this slide I like highlights is really look at the details in the photo. And I wish you could see them live screen, like how large they would be if you were looking at this on a TeleVue visit. I'm not sure how many of you do OTN appointments. It can be very challenging with our status quo that Prachi was talking about. The technology just doesn't provide that clear of an image, and the resolution here with the TeleVue stuff is really spectacular because this picture on the bottom left there is a zoomed in sort of photo of that leg, and I can see little staples that are still embedded where a skin graft was that probably should have been removed. We see levels of graft take. I can see the tissue, like the healthy granulation tissue that's also present. So these are really specific things we're able to see in a TeleVue call, thanks to that level of clarity. Let's look at a couple of case client studies here as well. This also highlights just how appropriate we can, not just myself, but we had a plastic surgeon that was in our wound clinic who was just down the hall on the day that I was presented with this on-demand call. And this is a client that was attending a community hospital daily for very painful dressing changes after a workplace injury with an alkali substance, which I believe was lime. And so with that, those kinds of burns actually tend to pass very quickly and liquefy tissue. So the recommendations that we try to, when we consider what's happening with the client, we are looking at things like, okay, this is getting done daily. It's very painful. What can we do to change that? How much drainage is there? What are we looking at? And of course, he's presenting to us on day 5. I think, 4 days after the burn. And so he had actually had a wound culture done. They had started some IV antibiotics for infection, but we made some changes to the treatment plan for something a little less irritating than the standard. We see a lot of the that silver sulfidizing cream that gets put on a lot of burns. It's very painful to remove, and burns already are quite painful. One of the things that we were able to do also is because I had the plastic surgeon down the hallway, I asked her, do you want to pop in and have a peek? So she came in and sort of shared my screen with me, and we were able to zoom into this client with the features of the glass from TeleView and see that he actually still had some hair follicles present deep within that burn. And so our plastic surgeon said, you know what, I don't think he needs to come in from, to our larger center because they don't have a plastic surgery in his community. She said, let's just change our care plan and do some watchful waiting. And so we followed him through the course of TeleView and with just some minor changes. And if we want to just take a look at the next slide, we'll see the progress and how quickly that happened for us. So with the pilot project, we have to set some goals for healing and sort of what we were looking for. And that's that 30 to 50% in 4 weeks. And generally we like to see that anyways, but for those of you who haven't done pilot programs, they're pretty particular about particular outcomes and goals that they would like you to meet. So that was one of them. And we were actually able to do this with the right changes to the care plan. So you see on day 12, we see him a week later after his initial burn. We've actually had quite a significant amount of closure there. And then day 26, we're seeing a lot more healing. Actually, he's nearly halfway there. And then by day 33, we have just this small area left of about 2.1 centimeters. Some crust was debrided, a little bit left, almost like 98% closed. So really, we achieved a lot. And that's a lovely slide, but let's have a peek at what that actually looked like for the client along the way. So there are the photos, and you can see in this first photo on day 12, I'm actually coaching the nurse at the site what tissue can be debrided or what can be safely removed. And I like this photo because you can see there's a set of hands there. So she's not holding a camera like she would have to in a status quo OTN visit. She's actually got her forceps there. And so there's that clinical teaching, coaching, interaction visit that's able to happen. Day 26, you can see that sort of, it looks like an extension of this burn, but all of that skin is intact. He's got a lot less pain, a lot less drainage. And then day 33, some more coaching there just to get rid of some crusts. And he had that small little bit that just wasn't quite ready to come off. So we let our dressings do that. And then we finally had a follow-up with him on day 50, but I do believe in 45 days or less, that was fully healed. So let's have a look at another client example. And on this one, this is another actually workplace injury in a small community hospital. Again, this lady, she had a very painful injury. I believe it was a steam under pressure burn. And so again, we were seeing her actually less than 3 days, so less than that 72-hour mark. So burns still evolving. However, they are using that same burn cream. It's painful to remove. She's basically has uncontrolled pain. The nurse that was working the ER that the client presented to this day, she didn't know anything about the TeleView glasses. However, we actually had a manager at the site who is also a nurse and former OR nurse. She actually went and grabbed the glasses and sort of took over the visit. And one thing I want to point out as well, in these hospitals, that these smaller community hospitals, they don't always have a doctor sitting at the desk when people come in. They're on call. Maybe they're not there, they're a phone call away, or they're somewhere in the community. So this nurse was able to sort of do all of these things simultaneously. Call the doctor, get some pain medicine, find what we're going to put on for a dressing. And we did it all together while I was in the call with her on the TeleView visit. This client had, as you can imagine, very large bullae, some smaller blisters. So just lancing and draining some of those things. under my guidance and under my direction, right over her shoulder, and then getting a nice, more comfortable dressing on there and decreasing the frequency of having to come back for her care. We were able to come up with a better plan for that client. And so you can see by day 13, approximately 2 weeks after, we actually had the plastic surgeon in our outpatient clinic. So I called her again. I said, you got to see this one. And she came in, had a peek. She did have some concerns about a darker area that you can sort of see in the middle set of pictures there, just on the medial popliteal space. But we actually instructed the nurse to sort of, push and manipulate the tissue. And the plastic surgeon was able to see some blanching and said, no, I think we're going to be okay here. Let's manage this too conservatively. And we continued with that type of care. And then on day 22, she presents and all that skin had reepithelialized and healed. So she had a really good outcome. The client was able to go back to work, and I'm really just pleased with how things turned out for her. And, she stayed home in her community. She didn't have to travel to Thunder Bay, and that would have been a few hours by car, and with a burn where you can't bend your foot, your leg, that's really uncomfortable. So that was wonderful for her. And then I think we'll take a look at one more client that we followed. And this guy was actually really a complex client, lots of health issues, the main one being MS. So he traveled by power chair. He was able to self-transfer, but didn't mobilize a lot. He actually didn't live near the community, the small community hospital. He was still 20 minutes away from that. So attending visits was very difficult for him. When he needed care, he did have home care. Home care, though, is quite scarce in a lot of these areas. And sometimes, they don't get in as often as they should. So we had this client, he attends the ER. We had made recommendations, and the case photos we're going to see in a minute are not from his initial visit. We made initial visit recommendations, and at that time it was early in the project. We weren't saving the photos. So we made some initial recommendations for vascular, and for one reason or another, they were recommendations and they weren't followed. And it may be something on the other end, he got into a little bit of trouble, and then we sort of lost him to follow up. So what we did was we're now seeing him several weeks after that, and he's in a bit of a mess. And the nurse at the site said, I'm grabbing those Teleview glasses, and she calls me up and we're going to have a peek at things. And actually he ended up we made the assessment, the recommendations. The ER doc that was on that day said, yep, we're calling up that vascular clinic and getting him seen. A key indicator was he had vascular surgery before on the left, but he's presenting with a lot of right side issues today on this visit. And so we know, even if they've had that revascularization surgery, that doesn't mean things are all back to square one and he's all better. And what are the odds there's something going on the other side? So I was quite suspicious for it then. And so at this time, the doctor's on board and we make those arrangements. However, the client travels by community van, an accessible community van. So this was in the winter time. Our roads can be quite treacherous. He did get an appointment with a RAVE clinic, Rapid Access Vascular, but he missed it. And he missed it because there were road closures. It was getting reorganized, and he got a new appointment, and then the transportation van broke down. So a lot of challenges for this client, just getting him to where he needs to have care. So in the meantime, really all I was doing was, making these recommendations that are going to keep things dry and stable. So ultimately he does get his appointment. He gets to vascular for his assessment in an outpatient clinic, and they directly admitted him to hospital. And within a day, he had limb-saving surgery as well. So let's have a look at some of the photos, because we were able to follow up with him after as well. So I'm seeing on the left side of your screen there's sort of 3 leg photos. The one, it's on the side of his leg, it's a dry eschar. I mean, it looks stable. He did actually have a lot of swelling that day, which is not captured in that particular photo. And then the 2 we see after that are actually from post-revascularization surgery. So the healing that sort of comes on. Same with the feet. On the right foot there, all these photos, you can see a very red, wet, weepy. There's some bone exposure in that 3rd toe. He did go on to have a partial amputation of that toe, but all these other wounds went on to heal. And let's have a look at the next slide as well. Just some more photos. There's sort of the side profile of that foot. Again, pre-vascularization in that first photo, and then you can see some healing that's taking place as it goes, reduced swelling. So we just kind of, I actually coached a little debridement in this one too, with the nurse, just the lifting crust right at the edge ever so gently and just enough. And yeah, we had a really good experience with that. Let's have a look at, I think there's one more slide. Yeah. So these are, there's that part of the foot there on the left, sorry, the left of your screen, his, the top of his foot. You can see nice granulating wound right on the top, or the distal part of the toe, and then the base of the toe, that's actually epithelialized. Some midfoot changes. He had a lateral midfoot. So again, this really, this is stuff I never would have been able to see with our existing technology, the details of the wound. You know, sometimes just seeing what is bone and what is non-viable tissue can be very difficult and challenging in a telemedicine visit, but we were able to really look at this, and he had a really good outcome.
Hi, everybody. I'm back again. So I'm conscientious of time, and I do want to get to the chat. So I'm just going to go through this a little bit quickly. So some of the challenges, Judy really touched on the inconsistent wound supply formulary. I think everybody has access to different things, and I think that was a challenge. But I think Judy was very flexible and eventually just started asking people like, what do you have? And I think that really helped her kind of address those concerns. Time intensive for a patient-facing clinician. So there's very few clinicians that are actually paid for wound care as a dedicated resource at their site. At least here in Northern Ontario, that is the case. And so whoever has the glasses on, you know, they have to do everything, and it does take some time. However, it wouldn't really be any different than an OTN visit. However, when you look at the outcomes that we had, we still feel that this was very valuable, but also that, you know, if you're pulling someone off the floor, if you're looking at an inpatient unit, yes, you're not really getting to all your visits at the same time because you are entrenched in this wound visit. So again, that's kind of a system issue that I'm sure many people on this call experience regularly. Connectivity on site, you do need a Wi-Fi connection in order to use the glasses. Secure storage with charging. So sometimes the glasses might have been dead if they were locked into an office. So that was something we just had to adapt with. Now, the people from TeleView are here on the call, and I know that they've come out with a wheeled cart that can actually charge the glasses consistently, and you can wheel between rooms, and they can answer questions about that if there's any specific ones. But that has kind of addressed that. And then on-demand services, so just making sure we could manage workload, but also we were trying to achieve a patient volume of 150 different clients, but we realized very quickly that maybe counting the number of wounds was a more relevant metric. And so some of our successful outcomes, again, we mitigated the wound formulary, as we mentioned, increased clinician satisfaction, support, mentorship, continuity of care. So a lot of wounds progressed to closure, and we were able to provide care closer to home. So in summary, we had 99 wounds total assessed over a 4-month period. We achieved full closure with 35 wounds. 75% reduction in surface area. And this is probably the biggest one, is that we saved almost 2,600 kilometers in client travel. And I really think that speaks to the need to do care differently, best practice informed care planning. And I do think that patients as well as client, patient and clinician satisfaction was also very successful. And so we're here to answer any questions in the little bit of time we had left. And sorry for some of the tech issues we had.
Thanks so much. That's very, very interesting. If anybody has any questions you want to put in the Q&A box, I do notice that some people have put some comments in the chat, and maybe we'll get started with them. Okay, so I'll put the question forward, and then you can decide who wants to answer this particular one. The nurse attending the patient is wearing the Teleview glasses, and it's projected to the wound care professional for advice, all operated on internet delivery. Why is it different than a Zoom or a Zoom communication? The glasses must be quite expensive.
Who wants to take that question? So, I mean, Teleview is here, but the glasses are actually not expensive, but I don't know if I should release the pricing. So, Ryan or Brad, if you're okay with it, or if you guys want to chat, but we licensed the glasses for 1 year, and they are very affordable. That's why we were able to give out 9 sets across the Northwest, and likely going to be doing more. I don't think Zoom is a secure platform, so I think that was largely why we weren't really able to, like, I wouldn't be able to use Zoom. We don't even use it at St. Joe's Care Group. This is Kathy's platform, otherwise you would have been stuck on WebEx with us today. So I don't know if I fully answered your question. I'm just trying to get through everything. I think I'll let Judy answer this. There's a question about how to handle a dehisced wound on a patient's leg. Judy, would you like to take that question? I just saw it pop up. I'm probably jumping the queue here. I'm so sorry. I'm not a good
You might,
follower.
Yeah, if somebody could read it to me, because I'm on my phone now.
Yeah, so it's how did you handle the huge dehisced wound on the patient's leg? It was one you showed earlier, and I'm wondering if it was the first case study.
I think the one they're referring to is the one with the skin grafting, I would guess, because it had a bit of a hole in the leg. Yeah, so that client actually, we were able to get a lot of that stuff cleaned up and closed below that hole, but I'm not, so I didn't follow this client after. I want to say, I believe she returned to plastic surgery or ortho for further, but yeah, it was packed with like a gauze packing. I can't really drop brand names, but it just depends on what the surgeon wants to do. And I believe she guided that interaction.
Okay, that's that's interesting. I'm gonna put this question back to Allison. Could you let us know, how did the patients react to this technology? I mean, this is pretty high tech coming into their home after most patients, I'm sure, were used to more traditional healthcare. How did they react?
Actually, I'm going to put this to Judy, because Judy was the one with the glasses interacting with the clinicians. And overall, I think when we submitted our questionnaire, because we gave each site questionnaires to give out to the patients, we asked how comfortable they actually were with the glasses, and that was a really big question. And I'll let Judy respond to that. But overall, most people were quite, they responded very positively. I will say that I presented at a Diabetes Network meeting in Winnipeg a couple of weeks ago, and to Grand Council Treaty 3. And one of the people there had said to me, you know, if you're claustrophobic, I'm not sure this would work for you. And that was something that I hadn't thought about before. So it's just something to be mindful, I think, when interacting with our clients, because we don't always know what their preferences are. But Judy, do you have anything to add there with the patient satisfaction?
Yeah, absolutely. As you said, we did the surveys, but even during the call, I would often, with the glasses, I could be overheard. So remember, I'm talking to the nurse at the site that's wearing the glasses, but there's a volume to it. And if it's up really loud, that's not the intent but some patients could hear. And so they were actually quite happy to interact with me as well. And they had a lot of really just synchronous planning. So what's important to you? How long have you been at this? I'm either asking questions through the nurse or the nurses asking them, and really it was well received. I had actually worried about that in the beginning of our pilot, but we hadn't experienced any poor reactions to it. People were pretty excited about it.
Okay, that's interesting. So in addition to looking at the patient experience and their level of satisfaction, what about the physicians and the surgeons that were involved? And do you think this helped you build a stronger interprofessional team?
Judy, do you want to answer that, or do you want me?
I mean, I can speak to
Yeah.
the surgeon that we had a couple of, so I had a vascular surgeon come into a couple of calls. And I also had a plastic surgeon. Everybody that I dealt with loved it. I do think that the most meaningful stuff for us is yet to come. I think I actually did an OTN ostomy appointment today. I would love to see this used for something like that. Very difficult to manage ostomy care with a status quo OTN camera. So yeah, it was, I think that helps, but I think it's really us that can still bring this forward and do it in our own clinics with or without our physicians.
And I'll add to that, because for lower limb preservation, we were working closely with the vascular surgeons here in Thunder Bay, and I wanted to kind of demonstrate the technology to them. And I wanted to know if we could hear Doppler sounds using TeleVue, because that actually didn't come up during the pilot. And so I just kind of walked into our outpatient gym, and there was a client there, and they're like, yeah, you can use me as an example. It's fine. So we had someone who had never used a handheld Doppler put a Doppler on this client, and then I walked into an office, and then I could actually hear the sounds for Dopplers, and I found that, so that was really valuable. So we kind of introduced that to the surgeons. They still would prefer an in-person visit, but it just kind of showed the value in, if someone doesn't really need to leave their home or their remote community, et cetera, they don't have to, because that does come up often.
Okay. So looking at the use of this technology in a home, did you have any issues with lighting? Or were they able, with the community nurse and the patient in the home, were they able to get the right amount of lighting to get the proper image?
Judy, do you want to answer that?
Yeah, I can certainly speak to that. We actually did one of our interactions of a young man with thumb injury at their kitchen table. So one of the home care nurses put the glasses on. Lighting isn't really a factor in most scenarios, any different than would it be if you were going to be performing care, because nobody really performs care in the dark, or hopefully you don't. But the glasses themselves have a flashlight. So if I can't see what I need to, all I had to do was say, hey, TeleVue, light on, and the glasses put a light on, and that's my little flashlight. Nobody needed to hold it and do the care. So that was not really a factor for us.
So the flashlight is built right into the glasses.
Yes.
Fantastic. Okay.
And not to make light of this, but the Zoom features are quite incredible. So when Prachi goes to teach people how to use the glasses, she usually talks about a mole on one of her colleagues' hands, and she'll say, "Zoom in, TeleVue," and then it zooms into David's mole on his hand. We shame David apparently, and then we're able to actually circle where it is, and like, so that really helps kind of like really enhance the image. And so we have had great success with the zoom in feature and the screen sharing, where Judy was able to share like best practice features and everything. It was really great.
Okay,
And
great.
to add to what Judy said just recently, the flashlight feature, as Judy said, she can control it. I've also heard that other clinicians found it very interesting when they're checking a tunnel wound, for that instance, like if they're checking that, that is very handy. Right, Judy? Did I say that right? Okay.
Yeah.
Yeah.
Yes.
Okay, so let's just talk for a moment about connectivity. Did you find the internet bandwidth at remote sites was a limitation for this technology? Did you have any issues with connectivity?
Judy, did you with I'm just thinking of the couple of remote communities that were serviced.
Not usually. A lot of the sites have Wi-Fi and patient homes have Wi-Fi. I think initially there was some issue trying to get things sorted out and making sure that when the glasses are initially set up, they're grabbing the correct Wi-Fi for that's the secure one. But that didn't tend to be an issue. There is also the feature, and the techie people can talk more about that if there's more questions, but the glasses can, if they drop the call like we saw today, if that would have happened, our glasses just reconnect automatically. I have the ability on my dashboard to lower the bandwidth so it's not so exhaustive, but to also increase it and really get that high resolution if I've got any concerns about some fluctuation there. So we had a lot of control over that.
Okay. There's a couple more questions that have come in through the Q&A. There was just a question about who's been using TeleView already, where is it available for everyone? How can we access it? And I do think Ryan put his email into the chat box. So just take a look, and I would recommend contacting Ryan directly, and they can fill you in on where it is actually being used. The next question was, how do you chart your assessment? And are you taking photos with this device? And I also wanted to know if you were taking videos with this device.
So I'll take that question as well. So there is capability to take video, to take photos. There's a web portal where everything is stored as well. And as for the charting piece, it was exhaustive, but we do a lot of exhaustive documentation just for clarity. What I would say is this would be a Ryan question probably. There was some discussion early on in my TeleView days about a dictation feature, which would also be helpful. The nice thing about TeleView is they're always sort of expanding, and they were very responsive to some of the things that I need to do this. How can we do this? So yeah, lots of diverse sort of expansion into different things we could do with the TeleView technology. And I really think we're just getting started.
Yeah, no, for sure. Now, Prachi, you work in change management, and I wanted to know, I saw that you saved, a couple thousand kilometers in people having to drive to patients' houses, and it may not have been even feasible for them to be able to drive as one of the value adds of this technology. Are there any other things that you noticed from a change management standpoint that have contributed to more cost value for your organization, or better clinical value?
Yeah, for sure. That's a great question, actually. So that number was based on just a pilot that we ran for just 4 months. The hope is that now we are implementing it in 9 different sites. The number will go up. One of the other success, like other than the kilometers saved, as we talked about, like glasses are mean to just, like increase confidence in a clinician. So there is actually one of the nurses who is in Sioux Lookout, which currently I hope I'm allowed to say this. They currently do not have a nurse specialized in wound over there in the whole Sioux Lookout area. So there was a nurse who was a patient-facing clinician. She got guidance from Judy, and right now is very much interested in becoming an NSWOCC herself. So I would say that is a success story. Somebody will be bridging that gap in Sioux Lookout, because when we talk about geographical area, especially in the context of Northwestern Ontario, I believe that it is not something we can fix, right? The area is as it is, but having that expertise at every different site is something that we can definitely consider a success story. And I definitely think that was. So, yeah, thank you.
Okay, interesting. And we have one, I can see this being easy in the clinic setting, but I wonder how it works in the reality of home care nurses being able to access the glasses. Is it really realistic that all home care nurses can have a pair of these glasses in the community? What
I would I would think it depends on how many nurses are in your organization. So one of the organizations that we work with services indigenous communities, but ones that you can drive to. And I think it was just one nurse that was servicing, and she was like a wound care champion for the rest of the group. And then at other organizations, they were able to share the glasses between clinicians. So it really depends. And one of our partners on this project, Community Paramedicine, they only have one set, but they yesterday asked me for 4 additional sets, and we're likely going to do that. So we're just trying to expand. The glasses are very affordable though, so it's probably less expensive than you think they are, and it's a 1-year licensing and hardware fee. But Ryan will go over that with you because I know he put his email in the chat, and I don't want to give away their pricing because I'm probably not allowed. So, so
And
yeah.
So we're at 1 o'clock.
Yeah.
I did want to say that one thing that I found when I was doing the background research for this webinar is that TeleVue meets all of the Canadian regulatory requirements and privacy requirements, and the data, the patient data is stored in Canada. It's not stored in the US or outside of the country, which I see as a clear advantage. And I'm sure Ryan and Brad can share the privacy regulations if you have an interest. And again, just look at the chat. They have added their email there. But now it's time to close the webinar. I would like to thank Allison, Prachi, and Judy for their contributions and your interesting presentation today. Always learn a lot from these webinars, and you definitely provided a new perspective of using technology in your clinical setting and applying it to change management within a health area. So thank you for that. And thank you again to Ryan and Brad of TeleVue, who are also on today. And I'm sure if you have any questions, they'll be happy to follow up with you. This webinar will be on a recording on the NSWOCC website, which is NSWOCC.ca. And so if you want to view it or have any of your colleagues view it in the future, it will be posted shortly. Thank you very much, and look forward to having you at our next webinar. Have a good rest of the day.
Thanks, everybody.
Thanks, everyone.
Thank you.